Okay, in this lecture we'll be covering imaging of the ankle and foot. So when do we request imaging of the ankle or foot? So we have typically with trauma, in pain, occasionally with metabolic disease or neoplasms, but very seldom typically. We may look at it for pre and post-op studies as well. So radiographic evaluation of the ankle. So the typical standard views are an AP oblique, and a lateral view. And occasionally some specialty views may include AP inversion and eversion stress testing films, anterior drawer stress test, and calcaneal view if needed for specialty items. So the AP projection is really just looking at the distal tib and distal fibula here. We'll be able to see the talar dome and a little bit of the ankle mortise, although you'll see some overlap of the distal fibula and lateral part of the tibia. So the syndesmosis is not viewable with this view. So that's one way you can differentiate the AP versus the oblique view, is being able to visualize the syndesmosis here. So typically the beam is just shot straight down into the ankle with the film underneath the foot and ankle here, giving you a pure AP projection. So here's the AP projection. So you see the talus, you see the tibia, you see the fibula, and you see this overlap here of the syndesmosis. So that's indicative of a true AP view, is that you see this. The lateral view, here you're able to see the distal tibia overlying fibula, typically overlying this. You see some of the talus here. You'll also see some of the calcaneus well here. You may be able to see the navicular and some of the cuboid in the background. So we're kind of looking at things here. So you'll be able to primarily see the midfoot and rear foot along with the ankle in this projection. So here you see the way the ankle and foot is on the table, the x-ray beam shot through here, and the film underneath the foot and ankle. So the mortise view here, it's a variant of the of the AP projection. This really gives us a good view of what this ankle mortise here looks like. So you can kind of see the opening here. You don't see an overlap of the tibia and fibula here. So you can see the syndesmosis here. Is this? We're really looking at this with like high ankle sprains, especially any type of talar dome fractures or osteochondral defects that may be there. And really want to look at the spacing in this ankle mortise. So, like I say, typically it's imaged with about a little bit of hip internal rotation to get this view, get this oblique view. So here's another view of it so that you can compare different films. So let's say the foot's a little more difficult to see in this because it gets blurred out, but you can see the mortise here. Okay, then you can do inversion, eversion stress, particularly if you're looking for ligamentous injuries for the lateral ankle, probably more commonly than the medial ankle. But if you have a deltoid ligament injury, this is a really good one to really look at to see if you have an avulsion fracture versus a actual ligament sprain. So you try to tilt it into 10 to 15 degrees, usually of inversion, 10 degrees or so of eversion, to look at these, and really looking at joint mortise space and the spacing between the mortise and the tibia or in fibula here. So this kind of gives you a good view of, this is a fairly normal view. The mortise doesn't change any with this, indicating that you don't have a disruption of the ligaments in this case. Here's a good indication of a positive finding with the mortise view, the stress view here. So you can see the different angle here. Got quite a bit of an angle here of opening. So you draw your lines parallel here, there, and then there. And then you can get a good appreciation of this angle right here. That's open space. That tells you the degree of opening for the ligament injury here. Like I said, as they tell you, about 15 degrees or more indicates a complete rupture of the ATFL and calcaneofibular ligament. You can also get a calcaneal view. Some people call this the Harris-Beath view. Usually we just call it the calcaneal view, so you can really look at the x-ray beam being shot down through the calcaneus onto the film that's underneath the foot. So you get this view of the calcaneus. You're really looking for fractures or a disruption of the calcaneus in some way. All right, that takes us to the foot. So our standard views here are the AP, the oblique, and the lateral, similar to what we did with the ankle. And then there's a sesamoid axial view that's done for looking at those sesamoid bones, in particular for specialty purposes. So the AP view of the foot is you're really looking just at focusing more on the foot. So X-ray beam is shot down through the foot with the plate underneath. So you should be able to see all the midfoot area, and then the forefoot, including the metatarsals, the phalanges, the tarsal joints here. So this would be a good view of the AP. So this one's labeled. You should see your sesamoid bones, all your stuff here. Your cuboid, navicular, you'll see parts of the talus and calcaneus here and how they interact, the cuneiforms as well. So you should be able to get a good view of the foot. Then you can do a lateral projection. So the foot is laid over the film here. The X-ray beam is shot directly perpendicular to the film here. So in this case, you're going to see the calcaneal neck and pitch, the calcaneus. You should see the midfoot alignment, and also the forefoot alignment here. It's difficult to appreciate some of these fractures that may be in the foot with this, but because they overlie each other. But you should be able to really be able to look at the arch and some of the more midfoot areas that may be of concern. So here's a lateral projection. Like I say, you should be able to appreciate the cuboid, in particular the navicular, cuneiforms, some of the metatarsal alignment here, and be able to look at this foot arch in relation, and also the calcaneus, a little bit of the, you should be able to see most of the talus here as well. So you're really looking at these midfoot joints, making sure those are in good alignment. And you can also see the arch here of the foot, the long arch. So, and then you should be able to see probably some sesamoid bones within the first metatarsal. The oblique, so you turn the foot a little bit. X-ray beam is still shot down a little bit, so you kind of see the angle of the foot on the tray here on the film. So it's slightly angled. X-ray beam shot straight down through, which gives you a little different view of the phalanges here. So if you look at it here, this gives you a better picture of how these joints line up, and particularly the spacing between the midfoot and forefoot. So you should be able to see all the cuneiforms, the cuboid and navicular in these joint lines here. So you should be able to see all these little spaces with the oblique view versus the some will get overlapped a little bit with the AP view. And then the sesamoid view. So you're taking a strap, you're pulling the big toe back so you can get a direct shot right into the sesamoids down onto the film. And so this is what you see is the metatarsal heads here. And there's your sesamoids setting in on that first metatarsal. So you should be able to get a good view of what's going on with the sesamoid bones, or if you have any disruption of the first metatarsal, you can show the alignment on this. But this is really more looking at sesamoid, and these bones can become fractured, irritated, or displaced. So being able to analyze those with this view is important for those specialty cases. All right, so that wraps up ankle and foot radiology. If you have any questions, feel free to give me an email. We'll be also discussing this more in our clinical cases in lecture.